Alright, welcome to another video from PharmD&ME, Intro to Hospital Pharmacy. Today we'll be talking about order entry. Alright, so who is responsible for order entry? Generally, it'll be the staff pharmacist working in the main pharmacy. Um, there can be any number of pharmacists, 1, 3, 10, just depending on the size of the hospital and the amount of orders that come in. I don't know if you would call it the main job of the staff pharmacist is order entry, but it's probably what they're going to spend the most time doing is order entry. And that obviously depends on the hospital and the exact job that that pharmacist has. But I would say typically it'll be their primary focus. Um, Clinical pharmacists can also order entry, especially if they have like a specific floor. Say they're in charge of the med surge unit, or they're in charge of the orthopedic unit, or the cardiology unit, whatever the case may be, NICU. So those people can enter orders for their floors or units, and again, it'll depend on the hospital whether or not they'll require them to do that or not. And then, depending on the size of the hospital, you may have kind of just standalone units. Maybe it's the ER, and you have a pharmacist who enters the order for ER or surgery or PEDS. Maybe you have a children's hospital that's attached to the main hospital, so they'll have their own little pharmacy. Same thing with surgery. Maybe they have their own little pharmacy for the surgery and PACU orders. So you can have pharmacists, satellite pharmacists working in different areas of the hospital inputting orders also. Okay, so how does the pharmacy receive orders? Uh, Most hospitals attempt to be zero paper or as little paper as possible. I think it was part of the Obamacare a couple years back. So typically the orders will come in through the hospital's EMAR system, whether it's Cerner or one of the others, and a nurse or a physician can enter those orders through the computer system. They can choose the medication schedule, timing. Um, uh, there can be some orders that just aren't easily put through Cerner. Um, like maybe like a TPN or certain drips with specific parameters and things like that. Sometimes those can be hard for the physician or nurse to enter it, or they just simply don't want to learn. We get that a lot. Uh, Maybe it's like a sliding scale insulin that most nurses have figured out how to do, but there's one that just can't do it. So what they can do then is they can just write out an order, make sure they have all the correct criteria on there, medication route, timings, schedule, when they should receive it, the physician's name, whether it was read back and verified, and all those kind of things. A patient label, date and time, and they can scan that over to the pharmacy, and then the pharmacist can input it from those orders. And also, sometimes you'll get a telephone order called in by a physician. Usually, it would be prefaced with like a question. So they'll call and they'll ask, "Oh, how do you dose a cardizem drip?" And you'll tell them, and they'll be like, "Oh, can you just enter it for me?" So that'll happen too sometimes. All right, so this actually might be the most important slide in this presentation, and it's the triage of new orders. Um, Orders, so the nurse can both, if they enter it through the computer or if they fax it over, they can enter it as stat. Um, so maybe it's an amiodarone drip, and they'll send it over as a stat order, like, yes, that needs to be done stat. Or it might be like a Levophed order or whatever the case may be, or maybe pain management or antibiotic or something. They'll send it over as stat. But sometimes orders will come over stat that just simply aren't stat. It's a lisinopril 10 daily dose, and they're going to get it tomorrow. That's not a stat order, but sometimes they'll come over like that. So you need to be able to triage. You can't just see like a stat order and always click on it, because if you're filling that lisinopril and not filling that amiodarone, then you kind of did it backwards. So the way I like to look at it, and this works like if, for everything you're doing in the pharmacy, is who's dying. So, maybe you just need to check a drip that's been mixed already. That person is dying. You need to get that order out first. So that's what you're going to triage. But specifically for order entry, I always look to see who's dying. Amiodarone drips, Levophed drips, antibiotics for someone in the ICU or in the ER. I try to get those out because you don't necessarily know right away why they need the antibiotic, but it could be an emergent situation. Um, so I look to see who's dying. The second thing I like to look for are drips that take a long time to mix. Um, I mean, not necessarily take a long time to mix, but drips generally take longer to mix than something that's going to be in the medicine cabinet. So that'll be kind of the second thing I'll look for. Is there any drips that we need to mix so we can get our technicians working and we can get this bag out the door sooner rather than later? Maybe it's an Ativan drip, and those kind of do take a while because it can be difficult to get the Ativan out of the vials. Um, so then the next thing I'll look for will be surgical and PACU orders. And the reason for this is, and I put a little asterisk there, but the reason for this is that they the longer it takes patients to get out of the surgical unit, get out of the PACU unit, is the less surgeries they can get done in that day, and the less money the hospital's going to make. And the more the surgeons are going to fuss at the CRNAs or at the other nurses or whatever, and then they're going to be calling the pharmacy looking for their orders. Um, so yeah, so that's kind of the third thing I like to do is you'll get used to seeing PACU orders. They all look very similar. Surgical orders will start looking similar too. You'll recognize them, and you'll be able to fill out those orders, or you'll be able to recognize them, and you know that how to triage those orders. And then the next one is ER, and again, I put an asterisk on it. The reason why ER and PACU orders have an asterisk on it is because a lot of times they can get those meds out of the Omnicell without needing the order entered. They can just override it and pull the medications out. So sometimes, depending on what's going on, like who's dying, and you look in the ER and they've got a Zofran, you're like, well, they're in the ER, the patient's throwing up, we want to get that order out fast, but the nurse can probably override that and give it to the patient in the ER without you needing to verify it. So you kind of just need to know what orders can be overridden in your hospital, and you know that you don't need to rush those orders per se, because the patient's at least, or the patient's at least getting the medication. Now the nurse won't be able to scan it, and they will oftentimes call and fuss that they're not able to scan the medication even though they've already given it. But that's, from a pharmacist's point of view, that's their problem, not your problem. You want to make sure that you're entering, you're triaging your orders. Who's dying? Drips that take a while. Surgical orders. ER orders. And then after that, you can kind of get onto some of the other ones. Maybe it's the antibiotics, or maybe it's, you can crank out the electrolyte disorder protocols or the daily meds. You can work on those other ones then. But these are typically the four that I'll focus on the most. And I probably could have added a fifth one, antibiotics. Probably could have been on the list too. Those should be a focus also. All right, so now to the main point with order entry. So you'll get your, all your orders will come through, and it'll be on like a queue page, or maybe you have your faxes page come over. So when you triage it and you find the one you want, you'll click on the order, and it'll pop up to a screen, and there you can look at the patient's height and weight and age and creatinine clearance, and even what they're admitted for and things of that nature. We can focus on that in another video. This one I kind of just wanted to focus on, like, the orders are coming through, how you're going to spit them out, and get the orders out the door. But yeah, so you would look at those things first. It'll pull up like a patient profile. You'll look at those things, and then you're going to enter the order. So order entry is actually really not that different than, order entry in retail pharmacy. The main difference is there's a couple extra criteria. It could be a little more complicated, but you're not dealing with insurance or anything like that, so it's really not too bad. So the components that you'll need to enter will be the medication. So these things will auto-populate. So depending on how the nurse or physician ordered it. So the medication, let's say it's Levaquin. So we've got a medication Levaquin. Well, is it IV or PO? If it's IV, you would need to choose the form. Are we going to mix it, or is there a pre-mixed bag of it? Is it a pediatric patient that needs a solution? So that's what you would choose in that category there in a medication. You would choose the medication's probably already filled in for you. You'll choose the dosage form and any diluent needed. So if you needed to mix the Levaquin, what does Levaquin go in and how much? 100 mLs of D5, 100 mLs of NS, just depending on the medication. So then the next one, kind of feeding back to that last one, will be route. So is it going to be by mouth, rectal, IM, sub-Q, IV, infiltration? This isn't a complete list by any stretch. So again, this one will probably come in auto-populated if it was entered through the computer. If any of these are entered by fax, you'll have to enter all of these categories. The next one will be scheduled, daily. It can be daily, BID, Q12, TID, Monday, Wednesday, Friday, Tuesday, Thursday. Basically any combination you can think of, hourly, Q2 hours. Any of those can be an option under schedule. And you'll just have to learn the little shortcuts. The BIDs or Q12 hours. Each system will have a way that they want you to type that in. Daily HS or daily at bedtime or just HS or however, each system will have its own way of entering it. You'll just have to learn how your system is. So then you might need to enter a rate. Say if it's the Levaquin 750, you'll have to enter a rate. So you can either enter it as a time frame, which will use for IV piggybacks, you'll usually enter as a time frame. So this one will run over an hour and a half. Say it's Rocephin that we're going to IV push. So it's only going to go in 10 mLs of NS, and you would put that one over, say, 3 minutes or 5 minutes. So that's kind of how you would handle those. If it is like a large volume, like say a liter of NS or a liter of LR, those ones typically get put in as a rate, so mLs per hour. So this one you would enter, say, 125 mLs an hour. You don't really care the time frame that it gets ran over. You just care about the rate itself. So that's how you do that. One that I do a lot is the Vinifer. It runs over an hour and a half, but if you type in the Vinifer in 250 mLs, it runs over an hour and a half. You get a weird number like 166.66 mLs an hour. So I've kind of just learned like, hey, when the Vinifer 300 milligrams and 250 mLs comes over, I'll put it as a rate of 165, and that way it's a whole number for the nurse to enter. They're not trying to get 0.67 entered. It just kind of makes things nicer if you can enter those whole numbers. So then the next one will be start times. This one can actually be a little more complicated than you would think. So let's say it's the Levaquin. The patient is on the floor. They've been admitted to the hospital. They put in a Levaquin 500 milligram or 750 stat, and if it'll auto-populate to like whatever the time is. So say it's 3 o'clock in the afternoon, it'll auto-populate to 3 o'clock in the afternoon. But if you go to the patient's profile, you'll see that they got a dose in the ER at, say, 11 o'clock in the morning. Well, you don't want to give another dose 4 hours later. You would want that dose to start the next day. So that's something you need to pay attention to. There can be other things of that nature. Say it's TID, it'll auto-populate that they need a dose now. Well, then the TID dosing for the hospital will start like an hour later. So you don't want to give them back-to-back doses. So you'd want to skip the next dose and go on to the dose after that. So just like the start times, it seems easy, but it can be a little more complicated, just based on what's going on with the patient and some of your like hospital timings and things of that nature. Maybe your hospital has a particular time of day where they give, let's say, Procrit or something. Procrits are given at 6 a.m. in the morning or whatever, and so you would need to make sure that you have those times set. Or maybe a better example would be for after dialysis dosing of medications. So when are patients going to dialysis, you want to set a particular time for them to get their dose after dialysis. All right, the next one will be day supply. This one is going to be hospital protocol. Lisinopril 10 daily, 30-day supply will be your protocol. Or it can be what the physician enters. So maybe it's lisinopril 10 milligrams, but they just want it for 10 days. So they'll enter it as 10 days. Different systems will work differently, but you'll either work off a protocol or what the physician wanted, and you'll enter orders that way. C2 narcotics are only good for 5 days, or C3 through 5s are only good for 10 days. Respiratory meds get a different length. Steroids can have a different length. And so it'll really just depend. And then all of that can be overridden by physicians. So if a physician wants Percocet going for 15 days, well, that overrides your hospital protocol. So you put it in for 15 days. Or maybe it's vice versa. Maybe your hospital protocol overrides the physician and you just put it in for that 5 days. It'll really just depend on how your hospital works. But again, the day supply isn't as easy as it should be. It can also be a complicating factor. The next one will be PRN medications and the reason. So is this medication a PRN? Yes or no? And then what's the reason for it? Example might be Tylenol 650, and they'll say PRN, but they didn't say why. Well, is it fever? Is it pain? Is it mild pain? Is it moderate pain? What are we calling fever? Is it 100.4 or 101? At what point do we put are we calling it a fever? So you really kind of got to make sure that all the parameters are entered correctly, and you don't have any duplicate PRN meds on their profile. So maybe they've already got a Tylenol, but it's a suppository formulation entered for fever. So it can get kind of complicated. You need to look over your PRN meds, and make sure that there's not any duplications, and call the physician and get that straightened out. I'm trying to think of what a good common one would be. Maybe it'll be nausea and vomiting, and they'll have 2 medications for nausea and vomiting, but it doesn't tell you which one to do first. Nurses aren't allowed to or aren't supposed to use clinical judgment per se. They're supposed to just follow orders. So if it should say nausea and vomiting, use Zofran PO first. If that doesn't work, you can go to Phenergan PO. And then, like, if that doesn't work after 4 hours, try Zofran IV, or whatever the case may be. But they should be clarified, and they're often not. All right, the last one is dispense location. This one will be hospital specific, but your med stations on all the floors and in the ER, etc., they'll have medications there. So a good program will auto set. Let's say you have the Levaquin 750 example again. Well, those IV bags are already on, the floor. So it'll auto-populate, send from med-surg floor, or whatever the case may be. But sometimes you will need to send it from the pharmacy. There may not be a drug that you keep on the floor, or it's a drip that you have to mix before you send out. So you would click from the pharmacy. Again, it should auto-populate where you're going to need to make this medication from. But like if you kind of go down the list, you need to enter everything correctly, or something could go wrong. Like maybe if you put the start time, you didn't pay attention to the start time, and the physician entered daily, but they never received a dose, and they need a dose now. Well, if you enter it as daily, it might pop up tomorrow morning. So they didn't get a dose now. So you need to kind of pay attention, like, oh man, they entered a Levaquin. They didn't get a Levaquin in the ER. I better give them a now dose. And then they can start their daily dose tomorrow. And kind of depending on your hospital, you may need to call the physician, or that may be just something that you can do on your own, a decision you can make as a pharmacist. Like, okay, the doctor entered Levaquin, they haven't gotten one in the hospital today. I'm going to give them a dose now, even though they set it for tomorrow, just because the physicians are used to just entering daily, and they don't realize that that means that it's going to start the next day. Um, so yeah, I mean, there any step of the process, if something gets entered wrong, it can cause problems. So you do have to focus on order entry. Uh, Most medications and most hospitals will be part of an order set. So the set will tell you exactly how to put it in. Everything's been entered correctly. All the labs that need to be pulled, all the medications that need to be entered, they're all entered correctly. And a pharmacist really needs to kind of just go through and double check for drug interactions and make sure that age appropriate and all those kind of things. Um, but there will always be some medications that you're going to need to go through and just double check and fix some things, and even a perfect order set might get the start times wrong, and you'll need to adjust those. So yeah, there's a lot to order entry. It's not that bad when you practice it, and if you're paying close attention, you shouldn't have too big of a problem. All right, so I don't really have much for the conclusion page on this one. The video's already gotten pretty long. But yeah, if you like what we're doing here, please like and subscribe, and I can continue to make more videos.